Good evening, I'm Shane Jones, and welcome to this very special and extremely important edition of CBC's News Extra. Now, over the past few weeks, Barbados has been consistently recording high COVID-19 cases, surpassing the 200 one-day mark today, recording 217 new positive cases. Now, these events have led the officials to explore different options and devise new plans to address this current surge. Tonight will be an opportunity for you to hear about some of these plans that have been in the pipeline for quite some time now. Joining me tonight as co-host is my colleague Lisa Lord.
Good evening to you, Shane, and good evening to our viewers. As you rightly said, we are at a critical point now in our fight against COVID-19, and here to break down some critical information for us is the Minister of Health and Wellness, Lieutenant Colonel, the Honorable Jeffrey Bostic. We also have the Director of Medical Services at the Queen Elizabeth Hospital, Dr. Clyde Cave, and the First Vice President of the Barbados Association of Medical Practitioners and Consultant Manager of Home Quarantine, Dr. Adana Grandison. Good evening to you all, and we're looking forward to some informative and insightful discussion. But we'll take a break here and come back now with some CBC News Extra.
Welcome back to News Extra. Okay, let's get straight to the meat of the matter. Minister Bostic, we are up to 69 deaths. That's the latest number we've heard, and a whopping 217 cases reported today. We know the isolation numbers are fluid, but the dashboard today showed 1,093 people in isolation. We have to be frank, it paints a worrying picture. Tell us about the current state of our isolation facilities. Are we overwhelmed, and what do we have to do to address this capacity issue?
Thank you. Let me say first of all that what we are experiencing at this point in time is something that we have been anticipating. And I say that because we saw the surge coming. And fortunately for us, we had done some surge planning prior to this, and we had some contingency plans in place to be able to respond to a Delta surge. And as a result of that, we started out quite well, and we were managing and coping very well. But within the last few days, admittedly, the numbers have been high hundreds, and now we've passed the 200 mark. But we also anticipated that because given the state of play with the number of positive cases that we've had over the last several days, it was inevitable that we would see these kind of figures. So in our planning, we've actually stood up a number of facilities to be able to deal with the problem, and we've been handling the problem at the level of the facilities. The current numbers that we are seeing really have begun to cause us some significant challenges within the isolation facilities, to the point where I know the numbers today are saying just over 1,000, but we would have cleared a number of those persons, and I believe we figured a more accurate figure is probably about 850. Okay. However, that does not take into account the 217 cases from today. So it is a challenge, and I would not say that the system is overwhelmed, but I would say that the isolation facilities are becoming overwhelmed. When I say the system, the entire healthcare system. But there's significant challenges that we are facing, and we have to find some ways and means to be able to respond.
Okay, tell us about those ways and means, because we've been hearing that there is a new plan that will be rolled out pretty soon.
Yes. All right. You would recall that I would have mentioned several press conferences ago that for us, the one determining factor, in spite of the numbers, because we always knew the numbers would come, would be our ability to respond, the capacity to respond. And at the moment, because that capacity is getting to the point where we are very, very concerned based on the numbers, sheer numbers alone, and also the human resources component that is required to be able to do what has to be done. We feel at this time that we have to go to another part of the plan which we were contemplating and conceptualizing for quite some time, and that has to do with home quarantine and home isolation in specific cases, and that is what we are looking at this point in time. And that would take some of the pressure off of the institutionalized quarantine and isolation facilities, so that we can leave those facilities, especially the isolation facilities, for those persons that the clinical team considers to be more serious and require that kind of facilitation.
And Minister Bostic, if you could, just so that for the sake of clarity, explain the difference between home quarantine and home isolation for us.
Right. The difference between quarantine and isolation. Isolation is for positive cases. Quarantine is for cases that are primary contacts, or persons, for example, returning from abroad, from countries, the part of the entry protocols for Barbados. And those are persons who would be awaiting test results and awaiting the period of quarantine before they are released and cleared. So it applies also to a home environment where you are allowed under certain circumstances to quarantine or to isolate at home. Quarantine, as I said, meaning that you are not positive, but you're awaiting results. Isolation means that you're positive. And so the two environments are kind of different in terms of how we treat to those persons.
Okay. Dr. Grandison, you want to jump in here in your new capacity?
Yes. So Minister Bostic put it quite nicely. When we talk about quarantine, we're talking about that COVID indeterminate person versus isolation, where we actually know the status of that person. As Minister Bostic stated, we want to ensure safety first. And so when we look at a person who is being considered, especially for home isolation, we need to ensure that that person is safe in terms of not being symptomatic, also having the lowest possible risk of going on to decompensating or deteriorating in terms of their status. And so we found that even with persons who are vaccinated, that if they do have a breakthrough case or they become positive, that generally they tend to have a lot better course. They tend to have decline, and this is internationally in terms of the research. What we have seen is that persons just about after day 4, essentially we start to see those CT values start to go down. And so based upon the risk mitigation that we have really looked at, this here would be the ideal person essentially to have in home isolation. An asymptomatic person and a person who's vaccinated.
Now, I know a lot of Barbadians at home right now watching this, and they're saying home isolation, home quarantine with the Bajans. You sure you trust Barbadians to do that? How confident are we Barbadians are going to do the right thing, or are additional measures need to be put in place to ensure that they follow the protocols of the home quarantine and the home isolation?
Right. So in addition to hoping that persons will do the right thing, we always need to have the redundancy in place. And we are using technological means in the form of a monitoring bracelet, a GPS bracelet, more so an anklet, which would be essentially installed once you're accepted for home quarantine or home isolation, where we would be able to essentially ensure that you stay home, because that is important. We will also have sporadic checks, and this is not something that is unique to Barbados. Australia, Canada, once you enter any of these programs, you would without any sort of notification, you could be popped in by a medical practitioner to assess you and to ensure that you're actually staying at home.
I want you to go into a bit of detail about these bracelets, right? Because I don't want tomorrow morning when we look at Facebook, we hear people saying that, you know, you got these things tied to somebody, tied to a table or something, because you know how it gets.
Right.
So I want you to detail and go into a bit more of exactly what these bracelets are.
So this is essentially an ankle bracelet. It is waterproof. You're not tied to a particular part of the house. You're free to move around within the confines of your home. But essentially what it does, because it uses GPS technology, is that it allows for geofencing. And this geofencing would ensure that you're staying based upon the setup that we have with the contractor that would be monitoring, is to ensure that persons do not go outside of the confines of, or what we would call the curtilage of their home, to ensure that not only they remain safe, but also the wider community remains safe. This bracelet is essentially very difficult to tamper with, and I have tried it. It can't be torn. It cannot be torn. This is a very safe piece of technology that has been used, and I'm quite impressed with it.
I would like to add to that, just for the record, that this is not the first time that we will be doing home quarantine. When at the beginning of the COVID pandemic, that was the only form of quarantine that we had. Yeah. Actually, it was home. Everything was done at home, but we've moved away from that as things progress. And this was always part of the process for us, recognizing, of course, that in several countries, regionally and internationally, most people actually isolate and quarantine at home. And it's only the very sick who actually go to hospitals. We decided to do it differently in Barbados, and we've been doing that very successfully, where we've been even hotel quarantining primary contacts. And we have a separate facility, as you know, for dealing with positive cases. But as part of the contingency planning, we recognize that if the system reached the point where what we're doing was not going to be sustainable, that had to be one of the things that we consider. And we are considering that in a serious way at this time.
But Minister, how will you determine who gets to home quarantine or home isolate?
Right, there's a set of procedures that will be put in place, and there will be a lot of public education about this coming shortly. But I can say to you, for example, if there's a team that has been trained to go and do house assessments, because we have to be satisfied that where your living conditions are located, that you can actually meet those requirements. So for example, a person who may be living in a household, let's say of 6 or 7 persons, and there was only one bathroom, that obviously would create some issues, because obviously people would have to be sharing that bathroom. And in this process, for example, what we're doing, we're trying to, this is being done when we actually roll it out, to take some burden off of the system at this point in time. Secondly, by allowing you to quarantine at home, we have to look after you, whether it be quarantine or isolation, ensure that your family is safe, and ensure that the community and everything is safe. So we have some measures that will be put in place, some of a security nature that will be outlined later on in the program. And also the fact that right now we do quarantining in hotels, for example, when visitors come. And we have a quarantine engagement unit that actually checks in with persons who are in hotel quarantine event for travel purposes. And that has been working quite well. And remember, we also have bracelets that we are using, geofencing persons and so forth. So it is not a departure from what we are doing at the moment.
And you're pleased with how it has worked in the past, because you said this is not the first time.
No, it's not the first time.
Okay.
And Mr. Boss, you mentioned that there's more security measures that you would look at later in the program, but we're on security now, so you could probably bring them up.
No, when I say that there are more security measures, because like I said, there's going to be a full PR part of this, but the geofencing, for example, that's one. There will be random checks, that's two. And there are some other things that will be put in place, which I will not mention at this point in time. of a security nature to make sure that people do what they're supposed to do.
I'm interested about the random checks.
Yes.
Because I can
Exactly.
see people already saying you can just turn up at my house at any time of the night. Whoa. Talk me through the random checks.
Random checks occur even
Right, yeah.
right now. They do occur. It may be a telephone call, not necessarily, all the checks are not physical.
Okay.
But for example, you are required to report your temperature at various times of the day. So that's a check. And if that does not come in, then a telephone call will be made to you to ensure that you're there, etc., etc. So there's some things that we do that will allow us to know what is happening.
But how able are you to do this? Because there's a concern about your resources already being stretched. You have to do checks, you have to employ other resources.
Right, you see, well, this program, and the good thing about it, both home isolation and home quarantine, these two programs are being managed and coordinated by private sector entities. With support, obviously, from the Ministry of Health and Wellness and the Queen Elizabeth Hospital Isolation Manager. So the resources are going to be provided, including a call center, which is also being outsourced. So this is really what is most helpful about this particular initiative, the fact that, and I mean in every sense of the word, it's taken the burden off of the current healthcare system and what it is that we are doing, because we are tapping into private sector resources, doctors, nurses, etc.
Where are we with the backlog of tests? That was
Sorry?
still an issue. The backlog of tests. Test results. We were still having an issue. From what I understand, some people were still having an issue.
Now, I can say to you that we have been having test results out in good time for the last several days, including today. And today there were about 2,400 tests that were done overnight, and the results were made available within the 24-hour period, unless there was some technical glitch, for example, maybe a wrong email address or something like that. But the results have been out for the last several days.
Okay.
Okay, and we just want to remind viewers at home that we want to give you the opportunity to get in on this as well. And the numbers to call are 228-5562 and 228-5563. Dr. Cave, we're going to get to you. We have not forgotten you. But Dr. Grandison, you said something. You said about the home isolation and quarantine. Who is approved? So am I reading this correctly? Can we apply to home quarantine?
Absolutely. So there is an application process. We are trying to use greener technology, so we don't want a lot of pen and paper. So this can all be facilitated electronically, which is a very simple form asking for demographic information, how many people essentially would be applying, what is the home setup like, how many bathrooms, how many bedrooms, and then essentially once also vaccination status, but then once that has been accomplished and we go through that first wave, then we deploy a home assessor, as Minister said, to go out and essentially ensure that the home is safe, safe for you, and also to ensure that there is as little contact with someone from the outside in terms of a friend or anything like that who may want to come into the home, because you know sometimes we have persons who say, well, you don't know your status, so I could come and relax and have a drink with you, but we want to try to discourage that. So once those two those two criteria really have been met, then that person would be considered a good candidate for home quarantine. For home isolation, the assessment is still done. The initial assessment is still done at Harrison Point or Blackman Gallup. So you would, once you get your positive result, you're still going for a formal assessment, taking a history. Let's get to understand what your symptomatology is. And then the home assessment component as well. And then if this person is a candidate for home isolation, then they would move back out to home isolation.
Okay, well, we'll take a break here and come back with more on CBC's News Extra. Stay with us. And welcome back. Dr. Cave, I want to come to you now. We talk about resources being stretched. The Queen Elizabeth Hospital is no different. Talk to me about the situation at the QEH at this moment.
Well, you know, the division of labor, as it were, was infected people in isolation, trying to keep the Queen Elizabeth Hospital as COVID-free as possible for inpatients. We still, in accident emergency, have to interface with the community. So whoever shows up in accident and emergency may be infected, they may not be infected, they probably will be sick, because we not only have COVID as a health problem in our country, we still have the usual and maybe even extra, because of COVID stress, health concerns. So yes, we were a busy hospital before. Our resources have been redeployed in many instances, not just in numbers, but also in experience. So obviously, yes, that has made a difference. Because COVID is not just about COVID infection, it's about people affected by COVID. So in addition to your chronic diseases, just the stress of living in these times is going to cause control difficulties with hypertension and blood pressure, heart failure, diabetes, all the things that we know about. It's difficult to eat and exercise in an appropriate way. All of these affect the other diseases that we're accustomed to dealing with. We're trying to deal with them in different ways, but that too has its challenges. A telephone call or a WhatsApp encounter is not the same as a face-to-face assessment. Many of our patients are not that comfortable with that. So one of the concerns of COVID is the neglect that people who are not infected at all are suffering from. When you think about it, we just talked about near 1,000 cases in the country identified with COVID. We still have a huge population of people with other health problems that we still have to look after at the same time. So yes, we are stretched some places more than others.
And the QEH recently issued a call for nurses to help out at the various isolation facilities, so that would put more pressure then on the resources that you also have at QEH.
Yes, administratively, the Queen Elizabeth Hospital looks after parts of the isolation facilities as well. Administratively, budget management, nursing, equipment, housekeeping, food, not just the obvious doctors and nurses that you think about when you talk about resources.
What happens if we do not start this home isolation quarantine?
I think when you look at numbers and you look at available resources and you just think not today but tomorrow, the numbers, we were in single digits not that long ago. Then we were 50s and then 100, and look how quickly we've gone from 100 to 200, and those are the people we're identifying. So there are obviously more of them who are going to be out there and presenting, not just to be admitted and hospitalized, but also in the community and maybe being asymptomatic and spreading it. So this is what we call the exponential spreading part of the curve, where even though it's unseen, a lot of things are going on. So when we look at where we are now, it's actually a lag of several days behind where the disease is and will be in a few days. What happens if we don't use all the layers of protection? I remember being horrified by CNN News, India, which seemed quite remote, even some of the more developed countries, there were parts of the USA, and then very recently, our own neighbors, Jamaica, the Bahamas, very distressing. That too can be us if we are not really very careful and use every layer of protection that we have available to us and use it smartly.
Dr. Cave, you just said with everything going on with COVID, there's still a lot of people that need care. Are you saying that because of what's happening, some people are being denied service?
We learned that in the first and second waves, where people selected to stay at home. We were telling them to stay at home and not come out. It was difficult for them to navigate, public transport and avoid crowds, come into the hospital and avoid crowds. I think we've done a good job in keeping the numbers of people in the hospital to a minimum. They are certainly a lot less than they were a year ago, but there's still that concern that you're coming into a crowd. And let's face it, the people who come to clinic are most vulnerable. They already have a pre-existing condition. So in staying at home, while that solved one problem of potential exposure to COVID, it created other things. There are some people who have been just refilling prescriptions, but that may not be appropriate as their health conditions have changed. So yes, I don't know that they are being denied as a willful act, but as a consequence of everything else going on. Yes, there are people whose care is not as optimum as it used to be.
Okay. And if we can get back to the home quarantine and isolation, Dr. Grandison, someone at home that's watching and saying, I may find myself in this position, they may want to know, what will I need? What will I need to do at home? What must my home look like? Are there any special requirements for the home and living conditions for home quarantine and isolation?
So really we want to look at the safety of the home let me start with home quarantine. Safety of the person and safety of, if there are other persons in the home, to ensure the safety of them. So yes, a separate bedroom, okay, from the other persons in the home. A separate bathroom, that would be ideal, but we do know that there are lots of homes that don't have 3 and 4 bathrooms. But certainly that the bathroom would be essentially a divider of the home, so that there's not a lot of square footage that that person who may be potentially positive passing and potentially infecting a space if they end up being positive. Certainly we want to ensure that you have the requisite modern amenities. But essentially what we are looking for is safety first for the actual patient. For isolation, there is really no difference. It is more so the health component that we're really looking at, because now that we know that you are positive, we have always attempted to get persons help very early in the disease course. And the reason that we do that is because early management of symptoms generally means a better course for the patient. So we encourage patients not, for instance, to stay home and wait until their symptoms have become very, very bad, and then they say, well, okay, well, I can't do anything more, so I now seek help. But if you, for instance, a lot of persons have been experiencing postnasal drip right now, and instead of staying at home and saying, oh, this is probably just a postnasal drip, I think it is important that we start to normalize testing. If you're not sure if it is something that wasn't happening 2 days ago, and you know this is one of the symptoms that you can potentially have with COVID, go out and get a test. Earlier testing, earlier intervention, better outcomes.
Minister Bostic, most people would prefer to quarantine at home in any case, in the comfort of their home. I know that you've seen a lot of complaints, you've heard the voice notes, you've seen the various videos. Tell us about, do you expect that the experience for persons will improve, obviously?
Yeah, I would say, obviously people would prefer to quarantine or to isolate at home. But I think it's important for me to state that the reason why this option is being considered is the fact that the capacity to isolate and quarantine in the institutions that we have, that we are now in some cases above 90% capacity. And what we are trying to do is to ensure that we are not overrun or overwhelmed, and that is why this is being considered. But there are some pathways for persons to be able to qualify to do this. For persons in quarantine, for example, primary contacts, we've been even putting into hotel quarantine entire families based on their conditions. That is, they don't have the facilities to be able to do things separately and so on. And all of these things would have to be taken into consideration, because at the end of the day, it's about the safety of the persons where they're going to be quarantining or isolating. And not every household or house will qualify. That's a given for either isolation or quarantine. But in our view, for example, in relation to those who are going to be in isolation, asymptomatic persons, for example, would be definitely persons for consideration, because obviously they're asymptomatic. We know that that can change, and that's why we have the medical team that will be monitoring those persons. But we want to keep the facilities for persons who are sick, and there have been a significant increase in the number of persons who are becoming sick, especially unvaccinated persons. And this is really the worry, and this is part of the reason why we are going along that road. But I want also to speak to about some of the videos, because this is very, very important, and I would have explained this before. I have to say to Barbadians, and say clearly, it is not business as usual. And the quarantine or isolation facility really is exactly what it is. We are in a war zone, a COVID war zone, and things don't, it's Harrison Point, for example, a lovely facility, but it's not a 5-star hotel. That's the reality. And then when we are confronted with situations that we did not plan for, like the one with the video, and I have to say this, we are getting a lot of children who are accompanying positive parents. And when we don't plan for that, and we don't have the beds, for example, at the time to be able to cater to those persons, then there will be some issues. But every time we have issues, we find ways to solve the problems. And that is the important thing here. So I am hoping that people will really get to understand what it is that we are doing and the situation that we are facing at this point in time.
Okay, well, we'll take another break here and come back with more on CBC's News Extra. Welcome back, and I do believe we have our first caller on the line. Good evening to you.
Good evening.
Good evening, ma'am. Go ahead.
Thanks for the panel. I have a concern, and appears prior to change from living life, economy. My true concern is if we have a big population, persons will not expect to come into Barbados, depend on tourism. And as well, we're talking about the concentration appears to be in households. But those persons in households work, they interact with people. So I personally feel that we need stricter measures. Yes, shutdown is not a possibility or being considered, but we need stricter measures to control the flow of people. Concentrating on vaccinations is really important, but at the same time, it does not deal with what we're currently going through. So that's my contribution, and thank you.
Thank you very much, ma'am. Minister Bostic, Dr. Grandison.
Yeah, that is fair enough. I don't have a difficulty with what has been said, but let me say this, because obviously the vaccines will take effect when we reach the levels of that we want to reach. However, I will say that even now, with the numbers of persons, 1 in 2 adults and so on, who've taken the vaccines, and the fact that the science is there, persons, we have, for example, about 503 persons in quarantine hotels, primary contacts. And we are going through the list, and we are doing some research. And out of about 140 persons, we had about 76 persons who were unvaccinated. And then these figures transfer into isolation. So I'm saying that the vaccines, at this point, there's still some impact for taking the vaccines. But the point is taken in relation to other measures. And for me, and I keep saying this all the time, if we do not follow the basic things that we have been, public health measures that we have put in place for the last 1.5 to 2 years, and this is where the breakdown really is. The fact that people are not wearing masks and doing the things that they're supposed to do. And in any setting at all, if that is the case, then we are going to continue to have problems.
If I could just ask Dr. Grandison to jump in here. I know I wear her BAMP hat. BAMP has been very vocal about instituting stricter measures. Is BAMP in a position to advocate for perhaps some no movement days like Jamaica did recently?
Certainly, we know that this is really a time where, for instance, if we don't put the measures in place that we need to put, Dr. Cave has said it, where the healthcare system, our sole public tertiary system is actually stretched, then we can have a problem. So we want to, and we hope initially that persons will do what we know they should do. But yes, from a BAMP standpoint, yes, we do strongly recommend that persons have additional measures put in place. We have spoken about increased testing. We have spoken about restriction of movement. And remember that as healthcare professionals, our sole concern is healthcare. Our sole concern is the health of the person. However, when we look at a country, we don't only look at healthcare. There are a number of other factors. Because, for instance, the psychosocial impact of COVID is something that's very great. The concern of uncertainty, the concern of not being able to provide for your family, these are very serious concerns. But yes, we do push for, and we will probably continue to push, we will continue to push for strict measures, especially if we continue to see us moving on the trajectory that we have been moving on.
And I just want to stick on that point, because you said you would like to push for more restrictions on movement. Explain that.
So essentially, BAMP has really made the recommendation that we know that locking down the country completely is not the answer. We know that for instance, we've come to being in a shared space. We've come to appreciate that there are many other things that help the country to stay alive. However, things like no movement days, more testing, and also I think it is important to really continue to analyze the data that we get. Just saying we have done X amount of tests, but not really analyzing what do these tests mean. Not just saying we have, for instance, COVID in this space, but what variant of COVID we have in this space, because these types of data sets that we can get actually help to inform our decisions so that we're not really reactive, but more so proactive in terms of our approach. So yes, we do think that we do need to have a bit more strict criteria, but I will say that even if we did not have those measures, it really comes down to the non-pharmacologic interventions. And back in 1918 with the first pandemic, I mean, Dr. Cave and I were talking about it. You didn't have vaccines back then, but certainly you had mask wearing, washing your hands, these very basic, which I think at this point in time we may start to fall behind on it, probably because of COVID fatigue, but I think we need to get back to the place where we are not just wearing our masks, but wearing our masks properly, washing our hands, and maintaining the physical distance that we need to maintain to ensure that we all are safe.
Minister Bostic, are no movement days a possibility?
All things have been considered and will continue to be considered, but there are other factors that have to be taken into consideration in relation to how we manage the overall COVID process. And whilst the Ministry of Health and Wellness will obviously look at things from a public health perspective, there are other things, and this is a much bigger activity and event than health. And we have seen that throughout the period of the pandemic, even with the lockdowns that we've had. And if you take, for example, where we are right now, we are seeing a lot of spread in communities and families, beyond a shadow of a doubt. Sometimes when you look at the figures comprise sometimes 26, 28 families. So the spread is going along those lines. If you look, for example, at some of the commercial entities where there have been some positive cases, we're not seeing that spread within those entities. And that's because of the protocols that are in place. And the one factor here really has to do with the protocol. So even if you had to stop movement for a day or a weekend, and persons are still within the communities and within the homes, then we're still going to have issues if the public health measures are not followed.
Okay.
Yeah. Lisa?
Lisa?
I do believe that we have another caller on the line. Good evening to you.
Good evening to the panel, and thank you so much for the work that you're doing. God is going to richly bless you. I do want to say that there, in many families, some are 4, 12, 6, and many homes don't carry 2 and 3 bedrooms or even bathrooms. Could it be a possibility that if some of these people return home and they are awaiting an answer to find out if they're positive or negative, and some might be, isn't it possible that it's already shared in the house, it's already passed? Is there another way that they can go? Is there another place that the government might be looking at in St. Lucie that is near, that you can probably renovate, put some beds, something in as quickly as possible? Just asking. Just putting it there.
All right, the current quarantine policy, let's look at it. So someone tests positive within a household. So the entire household now become primary contacts. So we place that household into hotel quarantine, and the families are together. The reason why we do that is to remove them from the community and so forth, so that there's no spread outside of that family. So if you have to put a family like that in home quarantine and there's a family together, then the same kind of circumstances that we would have applied to other situations would not necessarily be relevant for this particular situation. So they will still be together in the home, and that is a possibility.
Okay, we're going to take a short commercial break here and come back with News Extra. Okay, welcome back to this live edition of CBC's News Extra. We're going to go back to the phone lines and say good evening and welcome.
Hi, good evening. How are you doing? Could you please tell me what is the turnaround time from the time of the application process for the quarantine or the isolation to receiving an answer in the positive or negative?
Do you have the information already?
So the first arm of the application, which is the initial contact, we aim to have a turnaround time of 48 to 72 hours. But then you still have the home assessment to be done. Once your application comes in and you've passed the first section, essentially, of passing the minimum criteria for such, then you go into the home assessment. But the very first arm is 48 to 72 hours to answer that question.
Okay, thank you. We've had people not only calling in, people have been very engaging, wanting to know so much about this topic. We have a Facebook comment question I think we can pull up on the screen. Mm-hmm. Someone was asking about what does it actually mean for someone to be their status unknown. You know, we've seen that an unknown status, we're not sure if they're vaccinated or not. You know, people ask all sorts of questions. I'm sure that everyone here's Facebook and WhatsApp messages get flooded. Let me just back up one I saw this morning. They see someone saying their vaccination status is unknown. I thought y'all knew everything. Y'all following the science anymore? Y'all really feel y'all tricking anybody? When it comes back, their status is unknown. What does it mean?
Right. Unknown only because look, we have the system that we have at the moment, for example, we have, and it happens even with persons who may be positive. And then when you see unknown vaccination status, some of the private providers do not supply us with the information that is required. And so when that happens, you see unknown. And we recognize that this was an issue for a number of persons. And we have put some things in place now to try to correct that, because we can find out the information for vaccination by, if we go on the app, the SHARE app, which downloads everything, which has everything uploaded to it. So we are in the process of resolving that problem by doing a bit more work to find out the status of those persons. Within the public health care system, when we vaccinate persons or when persons go into quarantine or isolation, we have the information. So that is really why you would see that difference from time to time, but we are working to resolve that issue.
Dr. Cave, you want to get in here?
Yes, maybe if I can explain from the hospital perspective, when you come to accident and emergency, we are going to assume that your status is unknown. Not just vaccination status, because some people don't always tell us the full story, but you know that even if you are vaccinated, you can have a breakthrough infection. Or you can seem absolutely fine, think you have had no contact, be asymptomatic, and then we find out that you are COVID infected and possibly going to transmit it. So for the accident emergency status, that's what our initial assessment and triage is going to be. So it's more a way of thinking to keep all the people around safe, not just having some people show up in the belief that they are negative, so they should be able to self-direct in one way. So the concept and people's use of words, it's not pejorative, you know, when we say that it's unknown. We really want to find out, both for your own good so we can take care of you, but also protect all the other people that are around you.
Dr. Cave, while you're speaking right now, the rising numbers of the children under 18 testing positive, how worrying is that?
It is worrying. It is still true that children, even with Delta, tend to be relatively mildly affected. But we know with Delta, a lot more people are affected. So the more people you have, the more likely you are to find those outliers. So yes, children may have mild symptoms like a cold or a stomach upset. That's the usual kind of presentation in children, but it can be more severe. So that's why everybody has to be vigilant and assume that this potentially could develop into something further. And as Dr. Grandison and the Minister have been saying, people have to take personal responsibility to be checked and tested, not ignore until things are very severe. So yes, we are seeing more children. They tend to be mild just by going into isolation or quarantine. However, there are COVID effects that are not just from the infection. It's a disruption of school, a disruption of behavior, eating, normal activity, stigma. We're seeing a lot of preteens who are really worried. Preteens take on the weight of the world. They sort of think they are responsible, and they can sometimes in the household be the strongest advocates for vaccination, but because they can't be vaccinated themselves as under 12, there's a degree of guilt that we are seeing manifest itself as anxiety. So the effects of COVID on children are not just the infection, it's all these other associated things.
Okay, let's head back to the phone line now and take another call. Good evening and welcome to News Extra. Call has been dropped.
It seems we've lost our caller. Dr. Kev, I want to go back to children specifically. Tell me about what you're seeing in terms of children versus adults, in terms of how these symptoms are exhibiting.
Actually, for the most part, a lot of the children that we're identifying, that's through contact tracing. It's the adult or someone else in the household that presents. We have been seeing children with fevers, and many of them turn out to be dengue, for example. You know, it's not inevitable that because a child has respiratory symptoms that it's going to be COVID, but that is a possibility now. So we always have to entertain that whenever anything changes with a child, just like an adult. And I think children, because they are in our society cared for by multiple people, they can't be vaccinated because of the age, and wearing masks in the very young children is an issue. They are one of the most potentially spreadable people that we have within our society, and we have to take that into account.
In your practice as a pediatrician, are you still seeing a lot of hesitancy from both parents and perhaps the children in taking a vaccine?
There is some hesitancy. I'm not sure if I would describe it as hesitancy. It's more a desire to have the information which they've heard personalized and be reassured that yes, this is for them. I think many people know that they can have the vaccine and the options for it. Surprisingly, many of the people who should be first in line, like if they're asthmatic or overweight, which we know are things that can make a COVID infection worse, they're wondering if those conditions would be reasons not to get it, and it's the converse. Those are reasons why you should be lining up to ask for a vaccination.
Okay, well, we have another caller on the line. Good evening to you.
Hi, good evening. I was calling to find out specifically, Dr. Cable mentioned that they're trying to keep the hospital COVID-free. Does that mean that everyone is being tested, including the healthcare workers and every patient that comes in?
Yes, you are quite correct, but when you think about it, testing every patient and every staff member would only be good for probably a few hours, at most a few days, and to have a system where vaccinated or unvaccinated, we rely on testing alone would not be feasible. So we get back to the multiple layers. We've actually worked really well so far in keeping the inpatients of the Queen Elizabeth free. Yes, there have been breakthroughs among patients. Yes, there have been breakthroughs among staff, and what we've identified is the staff breakthroughs are the same as in the community. They're acquiring it from community activities, not as a risk of being in hospital and getting it from a patient. And conversely, with wearing the correct personal protective equipment and procedures, our staff have not been transmitting it to patients in that kind of way. I think we have to accept in our society there will always be risk, but in the Queen Elizabeth with our protocols, it really has been minimized and so far very successful.
Okay, the phone lines are lighting up. Everyone's trying to call in, but before we get to our next caller, our production team is letting me know that there was a caller who did not want to actually come on the air, who said that she was at Harrison's Point and was not tested upon discharge. She said she also knows someone personally who was in the screening section at Harrison Point and then was transferred to the Lester Vaughan School. He was also not tested when he left there. 3 days after, he took a test privately and tested positive. The caller says she's concerned at the absence of testing before releasing people from the facilities. Minister Bostic, what can you tell us about that policy there?
No, I would have to refer that to the clinical persons at the isolation facilities, because that is a bit beyond my scope as a non-medical.
Have you heard anything about that before?
I heard that up to today, yes.
Okay.
Yes, so
Yeah.
we will.
There is some science why what seems intuitive to people would not be correct. We know that from the time of onset of symptoms, which may not be the same as the time as the test. You may be sick for 4 or 5 days and then you have a test. After a period of something like between 5 and 10 days, you are not likely to be infectious. But there are particles of the virus that could still cause a positive test. So doing the test might show that you still have remnants of the virus, but we know that you are not infectious. So what's the point of doing the test if we know when the symptoms started, we know when your test was first done, and sometimes in the test there are values that tell us if you are likely to be infectious or not. So it's not like other tests where you wait for an all clear. We have to take everything, which is why the questionnaires and the understanding of the disease is so important. We can't rely just on testing to say we are completely free. I know people would like that, but sometimes you can be incubating a disease and your first tests are negative, and if you really were in a suspicious circumstance, you shouldn't act as though that was a free paper and giving you license to do what you want. Similarly, at the end, even though you have recovered or been vaccinated, we know you can be infected again. So you can't rely on that, oh, I'm negative, and therefore I have license to do all sorts of things that we know that we should not be doing.
And just to be clear, earlier this year when we had the spike in January, February, wasn't there a standard that once you're asymptomatic, after 10 days you were released? Wasn't that the standard?
The science has changed. So at the beginning we were waiting for people to become negative, and we know that people were in the facilities for weeks and weeks until the whole world realized that the test was still positive, but they weren't infectious, and apologies, but if we knew then what we know now, that would not have happened.
You see what, that's why I'm glad we have you in, because especially for the caller just now, you see, she was very worried. She was very worried that she wasn't being tested on release. So sometimes people then leave saying that something wrong is being done, but that's not always the case. Dr. Grandison, you wanted to say something?
And also I think it is not only looking at a CT value statically, because for instance, they sought a PCR test outside of the facility. But I almost want to say, based upon what we know with the science, I am very comfortable to say that the PCR test that they probably would have had initially, provided that they had symptoms, versus the PCR test that they would have had afterwards, would have shown that they're actually not in the infectious phase anymore. So I think that it's not really just looking at something in a static, but also looking at the context, symptomatology, if you've been without symptoms for 2 or 3 days, and also the length of time that we had you in isolation as well.
I think we can head back to the phone lines now. Good evening and welcome to News Extra.
Good evening. Hello?
Hi, good evening. Go ahead.
Good evening to everyone. Mr. Minister, I have 2 questions for you, sir. You hear me?
Yes, I can.
Yeah, Mr. Minister, I have 2 questions for you. I need 2 questions. The first one is this. I would like to know, it's not anything to do with COVID, but it's a medical question anyway. I have a question. I would like to know where it is that we can utilize the services of some of these young nurses that came out from BCC and don't have, they have not passed the regional exams, and so if they can't pass that, they can become a registered nurse, but of course they will be a student nurse. I want to know if you can utilize some of the services of those nurses, even if you don't give them a full pay, but a stipend or something, to get them back into the nursing field and so in the process, they will prepare themselves for the regional exams. That's the first question to you, sir. You want to answer, or you want me to move on to the next question?
Yes, let me take that one first. Thank you. I can say to you that we have been doing that. We have actually employed some of those persons, and we would like to find a few more. But unfortunately, it seems as though most persons are already employed in other areas. But we can do with the services of some of those persons. So if you know of anyone who is interested, they should contact the ministry, because there's a facility there for persons of that nature to be able to assist us even at this time.
One graduate with her associate degree, I know she's working in the supermarket as a cashier, and the other one is not working at all. But anyway, Mr. Minister, moving on. I want to know if it is safe, or how safe is it if someone in the household had or was suspected of having COVID and went to I won't want to say isolation. The other one is what? Oh dear man, there's isolation and the other one is
quarantine.
Anyway, the point is, if that person was suspected of having COVID and they were referred to one of these centers, they spend a week or two. After they come back to the household, how much longer after coming back to the household can they fully integrate themselves into the household again?
Well, first of all, you said if the person is suspected of having COVID. If you are in quarantine, that suggests that either you do not have COVID, or if you have COVID, then we are going to be tested, and we are awaiting the test results to see whether or not you do have COVID. And if you are positive, then you wouldn't go to quarantine, but you will be in isolation. And once you are positive and you have gone to an isolation facility, when you are released from that isolation facility, then those persons should be comfortable that you have been taken care of at the facility and that there's nothing that they should worry about. I don't know if Dr. Cave or Dr. Grandison would wish to add to that, but generally speaking, that's the information I can provide for you.
I think you're exactly right, Minister, but at that point in time, as soon as you go back home, depending on your activity, you may re-expose yourself and the cycle starts all over again. Mm-hmm. So it's not just because you have been through quarantine or isolation and you come home, now you're free to go about and not mask or social distance. It is possible for you to contract it again, mm-hmm. and the cycle start all over. So as a society, we all have to be vigilant all the time. That's just the way it is now.
Yeah, well, we have another caller. Good evening to you.
Hi, good evening. Can you hear me?
Yes, we can.
All right. First, let me say good night to the whole of Barbados and listening audience, and to the seated panelists. I want to first thank the Dr. Cave and the other doctor for sharing the information about the asymptomatic primarily. And I have one or two things I'd like to contribute towards that and the question at hand. Now, we spoke about individuals who are asymptomatic, meaning they don't have any symptoms, and therefore they don't show any signs of having COVID. But once they're tested and you find that they test positive according to the PCR test, they're put in isolation and whatnot. My question then would be, individuals in Barbados who are walking around, who have been asymptomatic since the inception of this particular pandemic, who would have not been tested, who would have passed the 14 days, 21 days, or however many required days for the virus to pass through their body, although they have shown no symptoms, clearly if they're testing positive, that their body would have developed the natural antibodies to fight and protect them against the virus. My first question then would be, should these individuals who have developed clearly the natural immunity for COVID take the vaccine, which is a synthetic version of it, and therefore the efficacy of it can never be in comparison to natural immunity? That's my first question. I don't know if you want to address that first before I go into the second one.
So I'll probably start taking that question. So what we have seen with persons who get native infection, even if they're asymptomatic, is that generally they tend to have an antibody response. Now that antibody response could be either what we call binding antibodies, or we can get neutralizing antibodies. What we're really concerned about is the neutralizing antibody, the one that's going to go in there, kill the virus, get rid of it, and we go back to essentially a stage where we don't have the virus in existence that can affect us and cause disease. But what we have been able to see, especially with, like, for instance, even if we were supposed to do rapid antibody testing, is that we have no way at this point in time in really determining what is a binding antibody versus a neutralizing antibody. And so we always err on the side of caution in ensuring that, for instance, a person, although they may have immunity, we have even seen it. There are some studies that I think came out of Kentucky quite recently, within the last 2 months, that actually showed that persons who had native infection, some of them actually got infected within 30 days again. And it wasn't a situation where the PCR result showed a higher CT value, which one may say, okay, well, this person is probably essentially just shedding, but this is now some person who became symptomatic all over again, and certainly that is of concern. If we see these types of things happening, then certainly there is a need to ensure that the response that we are going to get from a vaccine essentially will provide better immunity, so that the likelihood of getting a breakthrough infection is a lot more decreased.
And call one question.
Well, it's interesting you should say that. I find it interesting from the standpoint that the individual who would have been asymptomatic to this particular virus, who prior to being asymptomatic would not have had the virus, and after developing the antibodies for the virus, should then turn around after developing the antibodies for the virus to then contract the same said virus again and then show symptoms. What I'm not trying to do here is to identify the difference between the two, but rather get a response to determine why then you say we don't have the means to do it here in Barbados, but I don't know if it's here in Barbados, but why then Mr. Bostic perhaps can add to this as a segue. If it is that we have individuals who actually is immune to COVID, why are we not testing these individuals rather than simply promoting the use of a synthetic version, which in some cases, sister, you might be right. There's some individuals who might, for whatever reason, after they created the proteins, contracted. I'm sure that's a very small number, by the way. But nevertheless, why are we not testing individuals to determine if they already have the proper antibodies? Therefore, we wouldn't have to vaccinate individuals who already show that they have the immunity already, but then we could focus more on a society of those who are more vulnerable rather than putting all these different measures in place, disturbing the entire country and everybody in the country, when the truth and the fact is, if majority of the people are indeed asymptomatic, I suspect that perhaps majority of them actually are already immune, and we are vaccinating people who already have immunity to a virus, namely alpha in most cases, and so doing wasting resources that we could be channeling towards those who are really the most vulnerable in our society. If there's a method or a test that's something that can be done to check rather than simply vaccinating people at random that may already be immune with a better immunity than the vaccine, why are we not deploying that test? And if so, what kind of test is that?
Well, you've given this a lot of thought, and I'm really very impressed at the insight, but there are a few things that are assumptions that you've made that are not correct. The natural immunity from a viral infection, in some viruses it's short-lived, sometimes it lasts for a longer period. For example, if you have chicken pox, you tend to have lifelong immunity, whereas if you have a cold, the next variant of that cold, sometimes the same cold, if it comes back after a period of time, you're susceptible once again. So it's not just that the natural immunity is superior. Actually, what experience worldwide has shown is that the immunity that we can cause to be developed by educating the immune system with the vaccine seems to be longer lasting and maybe a bit wider spread. The other fallacy in the thinking is that if everyone were infected at the same time, then what you're saying would exactly work. The problem is that short-term immunity may be developed by one person, and while they would not be susceptible for a while, the virus changes and there's another variant, or the immunity wanes and they're reinfected. So there's so many things going on at the same time. It's a really smart virus. It's changing all the time, and we've been learning a lot as we've tried to keep up with it. So it has to be a multi-pronged approach. Just waiting for, hoping that most people will be asymptomatic and develop natural immunity. We know what happens with that. That's what happened in Italy when the virus first appeared, and out of ignorance at the time, we didn't know what to do. So the virus ran its natural course, and the consequences of that are not something we would want to deal with now.
We keep hearing that this phrase a pandemic of the unvaccinated. We have in jingles, we have to the point now that we have to change the isolation policy. Just yesterday I had a conversation with a friend who told me that he can't get both of his parents who are over 60 to take the vaccine, and he's actually fearing the worst. He's seeing all these deaths happening, he's fearing the worst, and it's heartbreaking to hear how helpless he feels. What more can we do to reach this, I don't want to say stubborn, but this demographic that are so adamant that they won't take the vaccine?
Now we know, Shane, that a lot of vaccine hesitancy comes from predominantly lack of understanding and education about it. It's not that we think that our population is an ignorant population, for lack of a better word, but most importantly, this is the field of medicine. Sometimes we doctors don't always communicate in very simple terms. You know, we can quite often babble on in our own little world, and persons can be lost in translation. And I think that the first thing that we need to ensure is education. And certainly I think that we have started to do that, and it's something that we need to continue. But also a lot of persons are hesitant because they're scared, right? The unknown allows persons to be scared. Now we have been vaccinating here in Barbados, this is now what, from since March, yeah. And February, end of February, March. And certainly we have seen that this vaccine is safe. The studies that are coming out internationally are showing that the vaccine is safe. Yes, there are some persons, and it's not just simply a COVID vaccine, but probably any foreign entity that would enter their body can have reactions. Some of these reactions are very mild, but the very severe types of reactions that we can have are usually very rare, that we tend to have with the vaccines. And also then there's and disinformation. And I think that is also a pandemic in itself, where persons have really attempted to muddy the waters, to misinform the public. And I think that once we tackle those three prongs, I think it usually helps in terms of getting those persons who may be a little indecisive to really make that decision that's best for them.
But you know, Shay, I think as doctors, we like to think that we can convince everyone. I think a consequence of freedom of choice is to make the wrong choice. The difficulty with this virus is the choice not to be vaccinated and to protect yourself doesn't only affect yourself, because if you become infected, you can spread it. So your decision as to how you choose to protect yourself affects the rest of us in this room and in this society. So that's why there's such a big push so that everybody can make the best informed choice that they can. And I think we have to accept that sometimes education alone still allows somebody to make an alternate choice, and it must be extremely stressful for your friend to see his parents make a choice that he may not agree with, and they probably feel the same about him.
Shane, I want to also say, I know that we get concerned about the severity of the illness and certainly death, but there's also another part. There's long COVID, right? Where quality of life is affected long term. And I think that sometimes we say, well, majority of persons are not dying from the disease. So
hold on, let me stop you. You just said sometimes doctors Babylon. You said long COVID and went down the road. What is long COVID?
Sorry. so that is essentially a constellation of symptoms that persons may experience after the acute infection. Things like mental fog, feeling very tired, chest pain, shortness of breath, persons actually having less cognitive ability. Sometimes they may get excessive headaches, these types of things that can affect you long term. You don't want to be waking up every morning. We've heard several persons who have had the acute disease profile and have gone on to say, you know, before I never really walked around with an oxygen tank. Now I can't really walk very far without having oxygen to assist me. And so it's really a quality of life situation. I think that is very, very important. Do you want to, yes, you may live through the acute infection, but then what type of quality of life do you have afterwards?
Minister Bostic, on the topic of vaccinations, we're moving closer to having about 40% of our population fully vaccinated. What number are we looking at to have vaccinated to achieve herd immunity?
We are looking at about 75%, 75%. Of course, if we could shoot higher than that, we will go for it, but that's the benchmark.
And I know that you wanted to make a special appeal, you told me earlier.
Yes, I wanted to make a special appeal because, and part of my appeal actually ties in with the question in relation to the deaths and so forth, because I'm sure that Dr. Cave would agree with me that what we are seeing, and it goes back to what we were seeing back in January, February, where there's an increasing number of persons who are presenting to the accident and emergency when they are very ill with serious problems, and this is an issue, and the outcomes are not good when that happens. And that is why back in January, February, we had to initiate the Operation Seek and Save, and we are now at that point again. In fact, I would say it's worse perhaps than it was back then. And I want to appeal to people. We have to dig deep as a country. We can stop some of the things that are happening from happening if we dig deep. We have to dig deep to protect our children. We have 200 and, the number changes obviously during the day, but about 256 children in isolation. We had 44 positive cases of under 18 persons today alone, and that number is climbing. We have to protect our children. We have to protect the elderly and persons who are sick, irrespective of their age. We have to ensure that we get them where they need to get to be provided with health care before they get to the point where they are in trouble already before they arrive. And this is an appeal that I want to make to the people of Barbados, because we are seeing it far too often.
And it's not the first time that you've made an appeal.
It's not the first time.
So does the messaging need to change?
I don't know, maybe the messaging needs to change, but I'm going to repeat it and repeat it and repeat it, because we have to save lives and we have to protect livelihoods. And I will repeat that every time, but it is a problem. It puts pressure, and significant pressure, on the accident and emergency department. And I can tell you that last night was not a good night at all at the Queen Elizabeth Hospital because of these situations.
And when you say it wasn't a good night, I'm not...
Because the numbers,
okay.
Dr. Cave can probably provide.
Yes, as we said, people coming to the accident and emergency who are sick, it may be COVID or it may not be. There's a process of testing and waiting results before we, while we stream you into lower risk or higher risk. Our higher risk area was full. The new accident and emergency extension, which we have had to repurpose to use for our COVID isolation, because that's where it has the highest technology, negative pressure rooms and that, but it's not enough for an unlimited supply of patients. And we had the rooms filled, and we had the corridors filled, and we had 20 people waiting outside to be assessed, many of whom needed to come in. So we then had to spill over to the outside areas that we have been preparing, where under the tents we have oxygen stations. But as you can imagine, this would be just happening, and what was our limiting factor was our stretched staff, because that staff has been moved to isolation positions and to the other wards and all over, and all of a sudden we're seeing now another hotspot, the accident and emergency, suddenly requiring extra resources. And where do we get them from, especially in short notice? So last night things developed suddenly. We have come close in previous nights, but we never reached there. And the hope is that tomorrow we might be a bit better prepared, but if these numbers keep climbing, there are going to be changes that affect us all.
Okay, I think that's a good place to leave it right there. We want to thank everyone for contributing tonight. Of course, we had the Health and Wellness Minister, Lieutenant Colonel Jeffrey Bostic. We had Dr. Adana Grandison as well as Dr. Clyde Cave. We want to thank you at home for joining us, and I want to thank my co-host, Lisa Lord. Thank you so much. I'm Shane Jones. Good night and be good.